Welcome to Between Two Psychs, a podcast where two psychologists and board-approved supervisors deep dive into many of the questions and challenges that provisional psychologists and early career therapists face in everyday practice, during training, throughout the internship, and beyond as they progress into working more independently. Your hosts Isabel Tombleson and Claire Trevitt talk about a range of topics specifically relating to psychologists and therapists who are just starting out.
Hi, Claire.
Hi, Isabel.
Hello. It's good to be back.
Yes, it's good to be here.
It is. So we have talked about what we would like to share with our listeners today, and I am going to speak about substance use disorders, treating addiction.
I'm really excited for this episode. I think our listeners are really going to learn a lot from you.
Yes. It's a bit tricky. I remember when I was training, we didn't spend a lot of times talking about addiction. And I think when I'm helping my 4+2s get through their programs and I'm thinking about other people just in like general counselling and social work therapy spaces, we don't, unless we've had a placement in a substance use or addiction service, we don't often get a lot of exposure to it. We know that it exists. We know that people do it, but maybe sometimes we're not always aware of it or assessing for it. And then if it does come up, not knowing then what to do with it. So we're going to talk about that.
Great.
Yeah.
I think, as you say, it's also, if we're not necessarily going to be treating it, just knowing what to do and what avenues that we have as clinicians for referrals can be extremely helpful.
Most definitely. Yes. So first of all, let's talk about some statistics. So in 2022, the comorbidity guidelines here in Australia found that 35% of people who were presenting with a substance use disorder also had a comorbid mood, affective, or anxiety disorder. That's
Wow.
in our adult population. And there's some other statistics as well, talking about an even higher prevalence of co-occurring substance use disorders and anxiety disorders. I think it's about 45%.
Gosh, really?
And then we've got even some more information about the challenges that people with a co-occurring substance use disorder have when they are presenting for treatment. Dropout rates are much higher for people with a co-occurring substance use disorder, and engagement and long-term engagement and recovery through treatment is a lot more challenging and a lot harder to achieve for a number of reasons. So this is the reason why I guess I work in this field, because it's quite complex and tricky, and we're holding I feel like I'm juggling many balls in the air constantly all the time, because I'm not just kind of treating, a mental health presentation in the traditional way that I was taught as a psychologist. I'm treating a substance use disorder that sometimes creates a co-occurring mental health condition, or even if it's not meeting criteria for a traditional mental health condition, there's still mental health symptoms present that occur as a result of substance use. We then also have a portion of clients who present who have had a mental health condition prior to developing the substance use disorder. So I'm assessing and thinking about that and working out how do we treat that. Trauma, complex trauma, PTSD, complex PTSD are all very common co-occurring disorders with this population. And then we have all of the flow-on effects that occur as a result of some of our addiction people falling into other behaviours, such as engaging in antisocial behaviour, getting involved in criminal organizations or criminal behavior, getting in trouble with the police, having charges, having to go to court. We then also have the psychosocial stuff that comes with that, the impact of families, to children, to relationships, to work and occupation. Then you can have like people with lots of fines, and so they're not able to get a license, which then gets in the way of them getting a job. And you think about all of these things that I've just listed, a huge list of factors that we have to consider when we're assessing and treating someone with a substance use disorder. We have to be really mindful that it's probably too much of an expectation for one person, for one clinician to hold all of these things at one time. And Claire, I think you, when we were preparing for this episode, you mentioned that formulation would be really important as well in these early stages of assessment and planning treatment for someone with a substance use disorder and co-occurring mental health. So, and you're absolutely right with that. We have to be really mindful about how we proceed with assessment and how we gather the information as well from our clients, because rapport and developing trust is also a huge barrier to helping a person to engage in treatment in those early stages of intervention.
I can imagine that is a real challenge, because you've got so much complexity coming into the room here. And I can imagine people listening, particularly who don't necessarily have experience in this area, or people just coming into this this profession, and just thinking, where do we even start?
Yes. So I think most of us aren't working in a drug and alcohol space. Most of us are working in a space where we're providing some sort of mental health intervention, and that could be through NGOs, or it could be through health, or it could be private practice. And most of the time, I think we're not really considering the impact of a co-occurring substance use disorder with the populations of people that we're seeing. I think that's probably the biggest messages that I want to share with everyone today, is that when you are doing your assessment and you're working with someone who might be coming in for a mental health presentation, please make sure that you do assess for a substance use disorder. And the reason why I say that is it will add a level of complexity to and be a barrier to the intervention that you might be planning to do. And you might find that you've been working with someone, say, and you've assessed and decided that you want to address their anxiety, or address their depression, or do some problem solving around helping them to get re-engaged in work. The client might not have told you in the beginning, until they felt safe with you, that they're using alcohol daily, or they're using cannabis daily. And what do we do then? And so I think my message for you there is to think about and be aware of all of the services and options that are available to us in Australia to support you, to support that person with that substance use disorder. But also, strangely enough, there isn't really, other than a bit of motivational interviewing or a slightly adjusted approach to using CBT, most of the interventions that we use for people with a substance use disorder are the same as the ones that we use for people who have mental health conditions. The difference is that we need to collaborate with the client on which symptoms they would like to prioritize. And if it is the substance use disorder, that's when you might make those symptoms the priority in treatment.
I'm just thinking, coming back to your comment around inquiring about substance use in those early stages, because it is a question that would normally be on most intake forms. And how we begin to interpret that information, because as you're saying, it sounds as though clients might be coming in disclosing maybe moderate alcohol use, for example, but then over time we might discover that actually it's a bit more than that. And so I'm thinking that what that probably means is that it's more of an ongoing assessment, so where we do have some indication that somebody is using any kind of substance, even if it's occasional, to be continuing to check in on that.
That's actually really good advice. That continual assessment approach if you have any information about the person, yes, having any occasions of use of any substance, and especially alcohol, and we'll go into that a little bit later. It's really important because minimizing is a really common thing. I mean, I think we all experience a bit of shame and a bit of embarrassment if we know that we're engaging in a behavior that might be unhealthy for us. And that certainly is the case for people who are maybe misusing or using too much of a substance. So establishing that safe therapy space so that people can open up and be real with us is great. And then continuing to gather information as it comes to light, as the person's disclosing it, and trying to be brave enough to go there with the client and be prepared to really explore it and maybe have some knowledge about the effect of substances, alcohol in particular, on the brain, on mental health, will be really useful little psychoed pieces that you can use, that you can thread into your sessions to help increase motivation and maybe, encouraging your client to think about the effects of what they're doing and what steps they can do to make some change would be really good.
That sounds so important, that psychoeducation piece. And in terms of that, are there places that people can access this information quite readily in terms of where would we find that information to provide that psychoeducation to clients? Because obviously we can all look on Google and find anything, but where is where's the research held in terms of what's useful for us to share with our clients?
That's a real National Drug Alcohol Research Centre would be a place where you could start to go and have a look at some of the research on treatment interventions for substance use. And Monash University have the Monash Addiction Research Centre as well. So you could go to either of those pages and look through a huge amount of research that's been done in this space on the Australian population in particular.
Great. Thank you for sharing that. It's always useful to have somewhere to go to get more information.
Yes. And I think we wanted to talk about the types of interventions that we use as well with substance use disorder. So I thought maybe it might be good to give a little bit of an overview, because you might find it surprising that most of the interventions that we use in the community drug and alcohol space are the same ones that we're trained in as therapists. So the gold standard interventions such as cognitive behavior therapy, acceptance commitment therapy, dialectic behavior therapy, brief solution focus therapy. I've just received quite a lot of training in that recently, and I'm using that a lot in this space. I also use schema therapy and EMDR, modified versions of those, but I do use those in particular for people who have complex trauma histories that have predisposed or preceded their substance use. So, just know that the recommendations are that we essentially still treat our clients with the same interventions that that we use as therapists for mental health, that we just need to assess, monitor, and tailor those interventions, maybe including a little bit of motivational interviewing and some relapse prevention if that's the time that if that's appropriate for the client at the phase of their substance use disorder, alongside what you're already doing. And especially because we know that mental health and substance use go together, it's not really recommended to try and treat them separately. Does that make sense?
Yeah, that's great. I mean, it's good news in the sense that it sounds like if people are presented with clients who do have substance use concerns, then we can actually begin to use the therapies that we're already trained in, and that those therapies will lend themselves to treating those. Because like you said, there's so much overlap and concurrence with other conditions that essentially, there is going to be that treatment for either the depression or the anxiety or both, and possibly, as you say, very high overlap with trauma as well. I imagine that substance use is often a form of coping with some of the adversity and some of the mental health concerns that people have.
I'm so glad you said that, Claire. That's essentially what it is for many clients. I haven't had very many. I would say probably less than 5% of clients at the assessment phase have denied having a co-occurring mental health condition or denied having any mental health symptoms that needed to be addressed. When you are assessing and talking about collaboratively talking about a treatment intervention with a client who is reporting a co-occurring substance use disorder, what I would say to you is to just be aware of the types of symptoms that are arising from the substance use disorder. And if you want to have a look at the DSM-5 criteria for pretty well all of the substance use disorders, because they're pretty much the same. Most of the time, we just want to be mindful about the behaviours that are going on maintaining that substance use disorder. So that's where a cognitive behavioural approach and formulation can be useful for those symptoms. It's never going to be clear cut. It's always going to feel like a little bit messy. What I encourage you to do, though, is to just be collaborative and focusing on establishing and giving your client a positive experience in the therapy space. Again, I mentioned that shame and embarrassment and fear of judgment is very, very common for people with substance use, and it can mean that they shy away from engaging in treatment or even just divulging that they have substance use going on. So feeling safe with you is the most important thing, and collaborating with them. I like to use the analogy of walking alongside. I will walk alongside my patients. I will not judge. It's purely sometimes I say it's pure luck that I'm not in your shoes right now, that I'm not on in the other chair right now receiving treatment. You didn't, a lot of the time we didn't cause or ask for the things that happened to us that have led to us having difficulty coping, which have led to us using a substance use disorder. And so let me walk alongside you, share with you the knowledge that I have about this and about how it relates to how you're feeling and your mental health. Together we might be able to see if there's a way through this. And this might not be the first time that you need to engage in treatment, and often that is the case. Participants who go to rehab, or they come to community drug and alcohol or private options, it might take a few goes and a few practices. There's so much I want to say about this, but I will just pause for your comments, Claire, if you have any.
I just love the way that you said that you walk alongside these clients. It's really, although we're talking about, substance use disorders and treatment, which are very clinical terms, there's something very non-pathologizing about that approach. And it's very, as you say, very collaborative, because we do want to try and destigmatize and remove the shame as much as possible. I think for all mental health concerns that people experience. And I think the more that we can do that, the more our clients will begin to feel that they can trust and feel safer with us. And that will really lend they're much more open, I think, to the support that we can offer them, which is essentially what we want to give. There was one question I did have around, at what point should we be concerned around somebody needing more than support, more than the support that we can provide maybe in like a private setting or a community-based? At what point would more of an inpatient or a specialist service be recommended?
Oh, look, if you have a look through the diagnostic criteria for someone that you're working with, and they are flagging mild, moderate, or severe symptoms, so more than 2 of the criteria for a substance use disorder, whichever substance they're using, that would be the time when I would start enlisting some support. It's really, it's always important to not feel like you have to walk this road alone, especially if it's not something that you're really familiar with. So want to let everyone know that every single LHD in New South Wales, and probably other states as well, has a community health service. And in that community health service, there will be a drug and alcohol service, an outpatient community drug and alcohol service with counsellors, doctors, nurses, who can assist a person alongside the treatment that you're doing. They can provide the intervention for the substance use disorder. Sometimes it might just be a medical intervention, so helping a person to withdraw. Sometimes it might be just, having a checkup with an addiction medicine specialist and making sure that their health needs are being looked after and providing options like for medication for cravings management, things like that. But if you're in a big enough population, there should be some counsellors there as well, and they can do some of the more addiction intervention. They can work on the addiction goals that the client has, and then give you space to then focus on the mental health stuff. And you can initiate that anytime. Anyone can access drug and alcohol treatment for free in every single LHD. And I didn't know that until I trained in Clin Masters and did a placement in drug and alcohol. I had no idea that was available.
That's so good to know, isn't it? And it sounds like a very integrative approach whereby, because of course there might be some medical concerns with wanting to just assess, any kind of physical damage. I mean, we all know that, substances can really, they're not good for us. And just to assess the extent of maybe liver functioning and those sorts of things, I imagine it incredibly important. So having a service that can provide that comprehensively with different providers. And like you say, there's also that physical withdrawal, but then you've got that emotional withdrawal. And also, if there is trauma or there is anxiety and that is being masked by the substances, then helping these clients to find other ways to manage those symptoms without substances is also a huge challenge, I imagine.
And that goes back to what you were saying before about substances as being a coping mechanism. It's no different really to what some of our other clients might do in terms of self-harm or suicide ideation, other problematic addictive type behaviors like gambling or shopping, and maybe even some of those more covert things like just, that inner critic, those constant put downs. All of those self-harm behaviors are we can treat substance use in the same way as we treat those other symptoms as well.
You can imagine it's fantastic at actually numbing some of those, and quickly numbing some of those symptoms that can be really quite challenging, things that clients are struggling with.
Well, let's talk about those symptoms. Like, what is it that a person is doing when they're using a substance? And I usually break it down to two things. Most of the time it's an escape, and it's an escape from some sort of internal experience, a feeling or thoughts that we're having. Sometimes it's chronic pain. Actually, a lot of the time it's chronic pain. So if you've got a client with chronic pain, ask them about if they're misusing any prescription drugs or using alcohol to help them get to sleep. That's probably a good little thing to do.
I imagine prescription medication would be just as concerning as other substances, because even though they're prescribed for a purpose, they can still be misused or used to excess.
Yes, you're absolutely right. So kind of just going to a little side topic here, because it is probably important to mention. Yes, when we're talking about substance use disorders, this can include prescription medications as well. And so when we're assessing our clients and we're talking about some of their, unhelpful coping behaviors that they might be using to deal with any pain, ask them about any misuse of prescribed medication, benzodiazepines, which are Valium, and highly addictive, and any opiates as well, which are commonly prescribed to people when they've had surgeries. They'll be sent home with a couple of OxyContin, endone pills, or tramadol, and they're very addictive as well. So just a little side note about that. But I remember what I was going to talk about now. So talking about where we can, when we're using substances, often we're talking about either escaping some sort of internal experience. That can be one of the reasons why we seek out substances, to just escape what we're experiencing on the inside. But it can also be about sort of numbing and dissociating a little bit from what's going on in our lives. So it could be that we've got things going on that are stressful, work setting, family setting, relationships, and things like that. It's really common that a substance use disorder might develop during those sorts of stressful times, and it's a great way to numb and desensitize from all of that stuff as well. So I guess numbing and escaping, look, you could use those terms for the internal or the external experiences, but the point is to assess for them and find out and see if the client has their own words that they would like to use as to the reason why it is a coping mechanism that they're depending on. Is it helping you to escape? Is it helping you to avoid? Is it helping you to numb, to dissociate, to desensitize? And what is it, the thing that you're trying to get away from?
Yeah, that's so important, isn't it? Again, it's that use of language as well, because it's not pathologizing. It's trying to, as much as possible, reduce the judgment, reduce the shame, which I think is something that is so important for us in terms of building some kind of trust and safety for our clients. And they may not necessarily sense that immediately, but I think over time, if they really do see us as being supportive and not judging, but really wanting to help understand and get to the bottom of things for them, we're more likely to get their buy-in, I imagine, for treatment.
Yeah. Helping, just sometimes I think having one or two appointments where you help a person to have a space where they do just talk it out, and they're able to sort of, I like to say, put the pieces of the puzzle together. Oh wow, like this is why I'm doing what I'm doing. Oh wow, I didn't realize that my alcohol use really ramped up just after I had a loss, or in the context of experiencing some work stress. Bullying is really common, especially young people. Young people and substance use, that is a whole episode on its own. So thinking about all those factors, and just allowing a person space to put those pieces of the puzzle together, normalizing, validating, and if you've got some knowledge about substance use and mental health, like providing a bit of psychoed can be really useful as well. We were talking about where people can go, and I mentioned community health, but I also just wanted to mention as well, if you've got a client who isn't keen to go to community health for drug and alcohol treatment, there are some other resources that you can access just in the community through NGOs and the like. So you've got your typical group settings. So you could refer a client to Alcoholics Anonymous or Narcotics Anonymous. There's also many other groups that are being run. The other one that I'm aware of is Grow Rehab. So there are a number of Grow groups available across Australia. Through COVID, many of these groups became available online, and that still exists now. So if you're not feeling comfortable about going to an addiction support group in person, you could certainly look up Alcoholics Anonymous, Narcotics Anonymous, Grow, or even just in your Google search bar, addiction support groups in your area. They will, I'm sure you'll be able to find some like that. And I also just wanted to mention as well that there are many rehab facilities across New South Wales and across Australia. The sort of, I guess, non-government arm of rehabs are probably more commonly known and are more cost effective than some of the private rehab options. There are private rehab options for people who are able to afford that type of intervention, and not wanting to preference one or the other, but I would just like to say that there are benefits to each, different benefits to each of those. So you would want to just talk with your client about the length of program, the type of program, what the intervention that's used in those rehab programs, and just weigh up what the priorities might be for your client. And even if they don't want to go down that pathway, just being a person who can share that knowledge with them so that they've got some options and ideas to think about could be really good.
It actually sounds like it would be helpful to find out, because each area across Australia will be so different. So as a little sort of research exercise, if you like, to find out the local providers in our area, but also to get more information about the types of therapies provided, the type of service provided, because that sounds like that's also very important for transparency. So clients know what they're going to get when they sign up for something. You know, it's going to be a 3-week stay. It's going to involve this and this and this. This other provider might offer something a little bit different, and then clients being able to have a choice, because it sounds as though there's not one sort of set type of service that offers sort of a sort of cookie cutter approach, but it's very, very different. I have another question, which sort of, I don't know, it's a little bit aside, but I think it's relevant. And that is, alcohol is such a socially accepted drug, really. It's readily available. And, you know, so what are the safe limits for alcohol? Because it used to be, I think from recollection, it used to be something like 14 units for women and 21 units for men. And of course, the units are broken down into, like a glass of wine is something like 100 ml. So a bottle of wine, is it 8 glasses of wine, which actually probably most people in a restaurant wouldn't get 8 glasses out of a bottle of wine. And so in terms of what people are drinking, are there any safe limits around that and recommendations?
Okay, so I'm just going to provide a little warning to anyone who is listening. And if you are listening and you're really enjoying drinking alcohol and you want it to be a part of your life, maybe fast forward the next minute or two, because I'm going to make you feel very unsure about whether or not you should be drinking alcohol. The guidelines, World Health Organization guidelines now say that not 1 drop of alcohol is safe for us.
Wow.
Correct.
So it's completely changed. It's reduced considerably.
So in Australia, the Australian drinking guidelines still say that moderate amounts are okay. We are yet to review those and consider World Health Organization's recommendations. Alcohol is a level 1 carcinogen. It's the same as cigarettes, and we should not be drinking it.
Right.
Just
so the
really
World Health Organization is different to the Australian guidelines.
Yeah, and those guidelines, the World Health Organization guidelines, were only changed recently.
Okay, so that is recent information, because this feels quite that feels quite extreme, but I'm guessing that's come from some new research.
Yeah, that's right.
Yeah.
So we've known for decades that alcohol is killing us. I mean, it's well known in the research. It's only the World Health Organization that I guess in my opinion, have been brave enough to say it. So feel free to have a look at the WHO website and have a look at some of their articles and some of the research that they cite there on alcohol if you're interested in that. Current guidelines are that we can have, I think it's 10 standards a week for an adult, not more than 3 in a setting. I don't talk about this very often, because when I talk to my clients, I actually just tell them not 1 drop is safe now. So I don't talk about any amount being safe. But last time I remember looking at this, it was about 3, definitely not more than 5 standards in one sitting. And yeah, any more than that, you know, we would start to consider that being problematic.
So even if it's not problematic from a sort of substance use disorder, as in meeting those diagnostic criteria,
it has health. From a health perspective, it's problematic. Absolutely, you're going to increase your risk of cancer by increasing your intake by more than those Australian guidelines. But we know now that any drop is increasing your risk of cancer.
Yeah. Okay.
Yeah.
Okay.
And it's just in general really not good for you.
Mm. And I think, as you say, we've known this for some time, but of course there is that sort of those guidelines that people stick to. And I think it's also um, when we're looking at units of alcohol, of course, it's
Mm.
when someone says, "Oh, I just have a couple of glasses of wine,"
Mm.
I think we're probably looking at 3 or 4 standard drinks.
Yes, yeah, at least 2 standard drinks per glass is what I usually see at the pub. When we get our, standard glass, that's, at least between 1.5, 2 standards, I estimate. I'm not measuring it myself. And you might wonder to yourself, gosh, Isabel, you sound like really strict on this, zero intake of alcohol. And I will say my alcohol intake has changed drastically in recent years, and even more so in recent months since I looked up the new WHO guidelines. So I'm really, really mindful about when I drink and how much I drink. I'm very careful, and I pay attention now to how I feel when I drink, and I notice that I do not feel good after having more than 5 standards in a sitting at a special occasion. I am absolutely more anxious the next day. I'm absolutely lower in mood the next day. It absolutely affects how I feel and function. And I think it's so normalized in our culture. It's so not. I mean, it's just intrinsic to us. It's built in. You turn 18, you go and have a drink, like you go to the pub. It's this rite of passage. Any social event you go to, it's just alcohol is there. So I think
Very
for me,
normalized.
it's
Very
so
normalized.
normalized, and it's so 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 bad for us. So I've definitely changed. I'm really conscious now about my brain health. So, we talk a lot about risk of cancer with alcohol, but for me, it's more about the effect on the neurotransmitters in my brain and preventing cell death and degeneration, because that is what alcohol does to our brain, and that is why we feel more anxious after we've had more than a few drinks the next day, and that can flow on for a couple of days depending on how much you drunk. Why we will feel lower in mood, less motivated. It's because it is causing cell death and degeneration in our brain. It's reducing the presence of the helpful neurotransmitters that we need for functioning, in particular serotonin. So I would encourage anyone who is listening, and that's why I gave the warning before. Like, if you want to tune out of this, if you're not ready to hear this, that's absolutely okay. But I encourage anyone who is listening to think about how much you're drinking. Pay attention to the effects that it has on your functioning, on how you feel, and know that it is poisoning you and it is harming you. And I encourage you to think about doing something with that, and not just going along with what our society and our culture currently says is okay and acceptable and normal and part of what we do in order to communicate and feel relaxed in social situations or to relax after a day at work.
Because part of our job is around listening to the science as well, isn't it? And like you
Yeah.
say, 5 or 6 standard drinks sounds like a lot actually in one sitting, but when you sort of look at the full strength beers and you look at the size
Mm-hmm.
of a glass of wine, 2 or 3 glasses of wine would get you there.
Mm-hmm.
That doesn't sound like that much.
Mm.
So it's it's a very I want to say sobering thought. Um,
I love
and
it.
I think
Thank you for lightening it, because I've literally just been really honest with everyone, because I can't not be honest. This is the reality. This is what my experience and my knowledge has, how it's influenced me. And I do want this message to go out to other people. And I want this message to go out to our patients, to our clients. It's not okay if we're smashing ourselves on the weekend and then going to work. We shouldn't be doing that. We should not be drinking to wind down after working in our profession. We should be engaging in helpful, nurturing, nourishing activities and behaviors that model and facilitate growth in ourselves, so that we can model and help others to facilitate that as well.
And that actually, I think I'm going to segue slightly into like our new competencies that will come out in December 2025. And
Yeah.
I was delighted to see self-care.
Yeah.
and it's actually listed as part of the competency description.
Amazing.
Not just a bullet point sort of somewhere along the in the guidelines in there. It's actually listed there. Self-care and deliberate practice I think are just so important. And I think we owe it to ourselves, but also to our clients to really to look after ourselves. And I'm not sure that there's enough yet emphasis on that in our training. And I'm just so delighted to see it there in black and white because, we do owe it to ourselves, and it's so important.
Yeah. Okay.
Thank you for that. It was, I certainly learned a lot just sitting here listening to you. So hopefully our listeners have taken something, I'm sure quite a lot away from that. So really appreciate giving your knowledge to us.
So I think there are a few resources that I can probably provide to our listeners through our website if you'd like to download them. I've got a drug and alcohol intervention workbook that you can use that I put together, and you can download that, and it has all of the information that you need most of what I've talked about in here and in a lot more detail. It has elements of motivational interviewing, relapse prevention, the psychoeducation. So please feel free to access that if you would like it. And there's also an instruction manual for therapists as well. There'll be also some links to some of the websites that we mentioned and some of the services that are available for anyone who would like it or need it.
Thank you. And I will mention that I'm in the process of getting a resources page up on our website, between2psychs.com.au. And I'm hoping by the time this airs that it will be live. And if it's not, it's coming very soon.
Thank you, Claire. Look, I'm getting a website set up for myself now as well. So any resources that we have on Between Two Psychs website, I'm sure you'll be able to access on mine as well, and on Claire's. Claire's got her own website that you can go to for some other fabulous resources. While we're spruiking resources, we may as well just spruik ourselves and say, look, we've got websites, we've got resources. We are here to help you and support you on your journey.
Absolutely, we are. Well, thank you so much for that, Isabel.
Okay, you're welcome. Bye.
Thank you for tuning in today. If you enjoyed this episode, please take a moment to leave us a 5-star rating. It really helps others find the show. And don't forget to follow us on Instagram at Between2Psychs for more updates and resources. For more information and to explore everything we offer, head over to our website, between2psychs.com.au. We appreciate your